And also in young cases, we can do disc preserving surgery. No need to lose the disc. Want to faster a little bit. Now you see the disc moving. Then here is the immediate post-operative MRI. Then now you see the third month MRI. If you notice that there is a disc hearing, can be seen. In stenosis surgery, we can do foraminal decompression, I said before. In degenerative stenosis, UBE has the open surgery rule. To do total foraminal decompression, osteotomies, big tools, and multi-level surgeries can be done under the clear visualization. Please see this video. Another big advantage of the UBE, you can change your endoscopic angle. I'm using generally two different angle endoscopes. I'm starting with the 0. Then, if I need, I going to with the 30-degree endoscopy. Now you've seen the 30-degree visualization. Here is the left side traversing nerve root and the foramen. This is. And here is the contralateral side upper foramen. Again, we've seen under 30-degree endoscopic visualization. In UBE technique, we can use these strong tools, osteotomes. So this is a big advantage. Now, actually, we are doing the microsurgery under the endoscopic visualization and percutaneously. Now you see in the contralateral side disc management, and we can follow the nerve root inside the foramen without causing any instability. This is contralateral side, exiting nerve root. Then this is ipsilateral side, contralateral side. Again, traversing nerve root, ipsilateral traversing nerve root, and the foramen completely decompressed. Here you see again. Then here is the ipsilateral side upper foramen, or ipsilateral side or left side exiting nerve root and the foramen. You can see the under the 30-degree endoscopic visualization clearly. Then here is the again contralateral side, both of nerve roots and the foramens. Now here's the post-operative MRIs and immediate skin stitches. Another important point of the UBE, the success of the paravertebral in paravertebral surgery. The paravertebral surgery is the paravertebral or lateral pathologies are challenging situation for surgery because of complex structures. Foraminal or far lateral pathologies also can be dealt with UB effectively because of clear and wide visualization and independent tool usage. Paravertebral surgery area can be dominated effectively. Let's see a sample paravertebral surgery. Here you see the very severe L5, S1, far lateral and lateral complex narrowing. And here is the surgery. Here is the SAP of S1, tip of SAP removing with the tool. Also, we can use different shape and size, kerosene punches, osteotomes. I'm using for this the curved kerosene punches and rotatory kerosene punches. It's very important. Now, here is the very soft, flexible tissue. And we, in the surgery, we couldn't be sure about this. Is it disc or another thing? So we used for this the sharp knife. And also, I want to show you the sensitivity of the UBE during the surgery. You can use very sharp tools. Then we noticed that it was just the disc fragment. If the surgeon follow all the procedure steps, all the surgery became enjoyable under the endoscopic visualization. Then I want to show you the post-operative pictures. Now you see here is the foramen and here is the foraminal widening. In some of circumstances, stabilization can be necessary as an additional procedure. For example, to make stable after deformity correction or listhesis reduction or accurate instability, UBE is an alternative technique also for the open surgeries. In this video, also I will share you the endoscopic interbody fusion. You can put the different shape and size. Cages, almost all lumbar levels. It's a very safe procedure, and you can do everything under the real visualization. As a completion, UBE has a strong role in spine surgery as an alternative for microsurgery because UBE technique is based on microsurgery but performing under endoscopic visualization. Thank you for your patience.
Thanks, Dr. Hayati, for your presentation. Now, let's turn to Dr. Takaki Yashibuzu from Sir Amatsu General Hospital, Japan. His topic is full endoscopic transcambling triangle lumbar interbody fusion using UBE.
Dr. Sharari, merci beaucoup. I'm Takaki Yoshimizu from Shizuoka in Japan. Can you see my slide?
Yes, yes.
Okay. Today, I'd like to talk about is full endoscopic transcambling lumbar interbody fusion by using UBE. This slide shows today's contents of my presentation. At first, let me talk about the concept of our surgery. As you know, various approaches exist for lumbar interbody fusion. From this green area, we can access the disc without facet invasion, unlike these blue posterior access. The choice of approach is also the choice of risk. I emphasize the difference between these two areas in the point of no necessity to expose dura. Dural tear is a threat for spine surgeons. We always want to be free from this stress. Endoscopy can be applied basically to the posterior approach. Let me express about concept of transcambling triangle lumbar interbody fusion. We call it CARIF. Professor Sairio introducing this technique as a new approach for lumbar interbody fusion. Transcambling means accessing to the disc from posterolateral and inserting cage from extraforamen. This method has an advantage that the dura does not need to be exposed, and there are no risk for vital organs, but the decompression is done indirectly. I will talk about my thoughts on whether TRIF or CARIF should be applied. We experienced remarkable back muscle atrophy after full endoscopic TRIF using UBE. The patient was a 65-year-old woman with a complaint of intermittent claudication. 1 year after the surgery, there was no loosening of the implant and the intervertebral bone formation was good, but there was marked atrophy of the paravertebral muscles, and the patient still complains of back pain. This suggested that TRIF may not be minimally invasive to the muscles, even if it is performed endoscopically. In addition, there is a difference between TRIF and CARIF in the nerve protection during cage insertion. TRIF requires protection of the dura and nerve root simultaneously. On the other hand, CARIF requires protection of the exiting nerve root only. Multi-aspect protection is not a good match for endoscopic surgery because it takes one hand to hold the scope. This led us to believe that CARIF is a more suitable approach for endoscopic surgery and less stressful for the surgeon. Next, I discuss whether uniportal or biportal techniques are better for endoscopic interbody fusion. In Japan, there are several doctors who use the uniportal techniques for the CARIF. In these methods, the original tubular or semicircular retractor is used for cage insertion. The angle of cage trajectory is more oblique and requires a different skin incision than pedicle screw insertion. We wondered whether the size of the cage was really sufficient for indirect decompression in these methods. Therefore, as a solution to insert a bigger cage, we decided to enlarge Cambin's triangle by removing the upper part of the superior articular process. Scissor and drill are useful for resection of the SAP. Biportal endoscopic spine surgery does not use a cannula or retractor, so ordinary spinal surgical instruments can be used. This is a great advantage over uniportal to resect the SAP. There are two advantages to resecting the SAP, or in other words, preserving the inferior articular process. After resecting the SAP, the The IAP protects the dura and guides the cage insertion in the correct trajectory. It is like a guardrail that guides us safely to the destination. We set our goals of new interbody fusion. The key is inserting big cage from posterior without exposing dura. We needed endoscopic technique to reduce invasion. We combined UBE and K-reef and made minimum invasive lumbar interbody fusion. I will show our procedure with video and express how to. Set the portals just lateral from pedicle. Start from base of TP and do SAP dissection with radiofrequency device. Only we have to check the facet. We don't need to detach muscle more medially. Resection of SAP is the key. We need to enlarge Campbell's triangle for safe cage inserting. Cutting line is just over the cranial pedicle edge. After SAP removal, we can reach disc and get big working space. After enlarging the safety triangle, Biportal has an advantage in disc curettage compared with uniportal technique. We can use bigger size of device like curette punch to disc curettage. We use demineralized bone matrix and resected SAP as bone graft. Funnel is useful to bone graft through the portals. Insert the cage. We can use nerve retractor to keep exiting nerve root safe. I use fluoroscopes supplementary. In most cases, we insert 12 mm with expandable cage. Expandable cage has an advantage in indirect decompression. Insert the two cages with the same procedure from the contralateral side. Using two expandable cage is useful for correction of disc height and slippage. After putting the cages, we insert the pedicle screw percutaneously. We can use portals which for inserting cage just as it is. In this way, a strong intervertebral body fixation with two cages and 4 screws can be performed with foreskin incision. I will talk about clinical results of our cases. I will present the patient who is 73 years old male whose chief complaint is intermittent claudication. Diagnosis was L4-5 grade 2 degenerative spondylolisthesis. I performed UBE carry for bilateral size. 20 months after surgery, JOA score improved to 25 from 18. Recovery rate is 64%. It is good course. I examined the results of this procedure at 1 year after surgery. The subjects were 23 patients who underwent UBE carry at a single level and were followed for more than 1 year. The average age was 68 years, 12 males and 11 females, 17 cases of spondylolisthesis, 3 cases of stenosis, and 1 case each of recurrent herniation and foraminal stenosis were treated. The examination items were back pain, lower extremity pain and numbness, recovery rate of JOA score, and bone fusion rate at 1 year post-operation. The recovery rate of JOA score was 78%. The recovery rate of back pain was 58%. The recovery rate of leg pain and numbness were 67 and 78%. Bone fusion was judged as a request when cross bridges were clearly formed between the vertebra on CT at 1 year after surgery. And the fusion rate was 53% in 13 of 23 cases. Finally, I will discuss about the limitations of this technique. Carif essentially utilized indirect decompression, ossification of the ligamentum flavum, osteophytes extending into the spinal canal, and high-grade migrated herniation require direct decompression because correction with cage alone is not effective in decompressing. We need to counter plan for treating such cases. Performing TLIF is one solution as it allows for direct decompression, but we perform KLIF bilaterally, followed by endoscopic decompression surgery. This is more intensive, but results in maintaining a minimally invasive approach. We experienced a patient who complained of side pain after this procedure. The early postoperative CT shows swelling of the iliopsoas muscle. It is unclear whether the swelling was caused by the perfusion fluid or the hematoma, but it resolved spontaneously. I have told all contents of today's speech. Thank you for listening. If you have some questions, please contact with me from the address below. Thank you again for giving me such a great opportunity. Thank you.
Thanks, Dr. Takaki, for your presentation. It was a very interesting presentation. Now it's the turn of Dr. Zhang Wei from Hangzhou Hospital of Traditional Medicine. The topic of presentation will be the basic knowledge of EVE.
Okay, can I share my screen?
We'll see your screen. We'll see your presentation, but
I think the Takaki take off the sharing. Oh, okay, thank you. Can you see my screen?
yes, we'll see your screen.
Okay. Thank you for the introduction of the Dr. Chalali. I'm Dr. Zhang Wei from China. Good evening in China. Today, my topic is UB basic knowledge, included the basic concept, approach, and the location, instruments, and operation procedure, and conclusion. First, there is a basic concept. UB is an abbreviation of the unilateral biportal endoscopy. It is the endoscopy solution for the difficult case, especially the spinal stenosis. And it is similar to the arthroscopy, including the endoscopy portal and work portal. This is the history of the UBE. And Dr. Sun is my teacher, and he used the UB to deal with nearly the discal stenosis and fusion case, and nearly cervical, thoracic, and lumbar case. And I studied the UB technique in Busan with the Dr. Sun, Choi, and Park. The basic concept is arthroscopic triangular lesion theory. If cross separate, you cannot find the instruments under the endoscopy. Only the endoscopy and the instruments meet together, you can find the instruments. The Dr. Sun's living surgery shows the importance of the orientation of the endoscopy. Anatomy in lumbar is the multifidus triangle. It is surrounded by the multifidus muscle, and we worked in this area. And in the cervical anatomy is the rotator brevis and rotator longus. The influence, we must have the enough influence pressure, and we must keep the outflow fluidly. So I prefer to use the half tuber to keep the outflow fluidly, and Dr. Sun prefer to use the semi-tuber retractor. This video shows the outflow fluidly. Approach and the position of the portals. The approach includes the fundamental approach and advantage approach. The fundamental approach includes the discectomy or URBD for stenosis and the paraspinal approach for the foraminal decompression. And the advantage approach includes the contralateral approach and the ULIF approach, cervical approach, and the thoracic approach. This is the basic approach for the discectomy and the URBD. The horizontal line is the red line is located in the junction of the spinal process and the low margin of the lamina. The blue line is in the medial margin of the pedicle. And cross point above cross point 1.5 centimeter is endoscopic portal. Below the cross point 1.5 centimeter is a work portal. This is paraspinal approach. The dorsal side is isthmus. We draw a horizontal line in the isthmus, the below margin of the lower margin of the pedicle, and the lateral margin of the pedicle, and more lateral about 1.5 centimeter or 2 centimeter. This is a cross point above 1.5 centimeter is endoscopic portal, and below 1.5 centimeter is work portal. In the lateral X-ray, we can see the the line is located in the foraminal area. Contralateral sublaminar approach is used for the decompression of the double nerve root. I have show you in the case 2. And the translaminar approach is used for the disc fragment migrate downward. This is a uniform approach. The portal is more lateral.
Hello, Dr. Zhang. We cannot hear you so far.
”张伟主任，好像声音有点卡住了。Maybe some problem from the Dr. Zhang Wei's computer.张伟主任，
能不能就从头开始讲？
张伟主任，您那边的话，网络可能是有一些问题。Maybe some problem with the network with Dr. Zhang Wei. Please leave your email. Dr. Ostard. Hello. Can we change to another speaker? Dr.
Okay.
Kenji Sasaki from Japan.
Let me introduce Dr. Kanti Sasaki from Sir Ahmad Matsu General Hospital. The topic of his presentation will be cage insertion technique of ABE fusion. So it's your turn, Dr. Kanti.
It's okay?
It's okay.
Okay. Thank you, Chairman. Thank you, everybody. So I will talk about cage insertion technique with UBE. So fusion without decompression technique will be a good option of endoscopic interbody fusion. So what's MIS? Smaller skin incision, preserving structure, which is most important. Although it is important to reduce the size of skin incision, especially in spinal fusion surgery, sacrificing stability of the spine is contrary to the original role of minimum invasive surgery. MIS is a unilateral laminectomy with a cage, which minimizes skin incision, but destroys the facet joint on the one side. In ORIF X-ray, a separate skin incision of about 3 centimeters is made, but the destruction of bone, muscle, and ligament is minimal. If at the same time we can do a yellow ligament resection, then it means posterior decompression and fusion. X-RIF ORIF, if we need to decompression, we will need to add decompression from posterior. It means indirect interbody fusion only. The concept of indirect decompression by lifting the intervertebral disc is necessary to complete the fixation procedure without cutting the bone. X-RIF ORIF relies on indirect decompression. This is case presentation. ORIF is performed without bone resection, without ligament resection, but decompression completed. And the effect of indirect pressure reduction is widely known in papers. Otherwise said, pre and post-op MRIs can show the significant increase of dural sac dimension. Oh, sorry. Sato said lumbar anterolateral fusion without laminectomy may be useful for lumbar spondylolisthesis with back and leg symptom. Relief can insert large cage without bone resection. The shortcut to complete fixation is stabilize unstable intervertebral bodies by big cages. Usefulness of big footprint cages increase the disc height and correcting slippage sclerosis, can reduce deflection and thickening of yellow ligaments. We made aware of importance of cage size by relief. I started to think about whether the relief approach would be better or to put the big cage in correctly is better. This is a bad case of small footprint cage by tariff. Bone erosion progresses, sclerosis, and subsides. This inflammation and bone resorption is a specific phenomenon of small cages. The small cage cannot support the vertebrae, and the bones become inflamed and dissolve. Indirect decompression is only possible if the cage is stable. So of course, I know relief is easy and gentle for bone. So it's retractor depend, no bony dissection, no look of caudal equinia or nerve root, but I doubt it's safe or not, safe or dangerous. Potential risk of lumbar plexus, psoas muscle, and bowel injury and vascular injuries. And if it occurs, may be difficult to control. So minimum invasive, less invasive, and more safe surgery is modern style. Simpler and faster than the conventional interval diffusion, less invasive than conventional interval diffusion, safer than conventional interval diffusion. There is no serious complication. I still want to insert large cage from posterior with minimum invasive. Therefore, I came up with 2 questions for posterior fusion. First question, how to insert big cage like relief from posterior? How we can reap the benefit of indirect decompression from posterior? Second question, so how to minimize posterior surgery? Minimum invasive means small skin incision, less muscle damage, less bone resection. I want to complete everything as much as possible. So I met extrafemoral lumbar interval diffusion for the treatment of ischemic spondylosis in 2014 in Paris. So Bayek et al. Said they try to approach directly to region the existing nerve root to decompress and to stabilize with minimum invasive procedures. So through extrafemoral approach, we can expose the existing nerve root only to perform interval diffusion without intra-abdominal dissection or exposing central dura and traversing nerve root. Only partial SAP action, so the amount of bony dissection is quite small. Extrafemoral lumbar interval diffusion need indirect decompression. In order to achieve the consistency of result in IRIF that we saw in France, the footprint of the cage, which is less than 200 square millimeter in TIRIF, has to be close to that of ORIF, which is 900 square meters. If the cage is inserted from inside the retractor, the cage size will be smaller. The 360 square meter cage we are using won't fit in the PED retractor. So then UBE is without dedicated retractor. IRIF is without exposing dura mater. I think UBE IRIF much bigger cage insertion. If the cage can be inserted from both sides, the cage size can be increased to 720 square meters. Since IRIF has no destruction of laminae, thus it leaves a posterior element when inserted from both sides. The under 200 square millimeters footprint that started at IRIF is now up to 720 square millimeters, which is similar to the effect of 900 square millimeter relief cages. We reached to the indirect decompression. 720 millimeter bilateral side cages is powerful. Not only stabilize the but correction, spread disc, etc. Etc. We can manage stable cage insertion from posterior by UBE IRIF. UBE approach is slightly more lateral than normal decompression and hernia removal, and more median than PED. This approach is very easy to perform because the incision of the incision is same as PPS, and there are few hazards on the approaches. Why not TLIF? UBE TLIF means with decompression. Puts the cage under the endoscope with the dura and exiting nerve and exiting root being pulled is very difficult. And indirect decompression without bone resection is less invasive. The first thing I would consider to level difficulty in UBE is that herniation of the lower lumbar level is easiest, while decompression and TLIF are most difficult. ELIF is the next easiest after herniation, probably because it is performed without retracting dura and there is less osteotomy endoscopically. And if you can fit a larger cages, I cannot think of a better way to ELIF than with UBE. So UBE is approached from a slightly more median angle than PED or regular FLA. UBE fixation is performed using the modified FLA approach. The superior articular process is shaped. The combined triangle approach and indirect decompression. If the inferior articular process is completely preserved and superior articular process is removed, the inferior articular process acts as a retractor and does not damage of the dura mater. That increases the freedom cage insertion. So an approach that does not expose the dura with posterior penetration. Insert cage through combined safety triangle. Perform a SAP resection and enlarge combined triangle to insert larger cages. So posterior fusion from combined triangle by UBE is 3 steps. Only 3 steps. Step 1, SAB partial resection. Step 2, making working space at combined triangle. Step 3, disc resection and fusion. Oh, sorry. This is step 1, SAP partial resection. So only find the SAP, and this is SAP. And the facet joint now I am finding. Identify the facet and the resection, then resection, the SAP. This is facet joint. Then, so I am using high-speed drill to resect SAP. Dr. Yoshimizu always uses chisel. This is different. Free SAP, I can remove. Then checking exiting nerve root and remove this. This is a so left side is is exiting, and this is a resection of the SAP, And in the middle, we can see the vertebral disc. It's very important to remove SAP completely. Step 3, disc rejection and fusion. So this disc rejection and cage insertion without much bone rejection. So enlarged combined triangle is super safe. So our next step is unilateral double cages. UBE posterior fusion with PPS. So leg numbness disappeared after surgery. Conclusion at 60 cases. The development of relief has allowed me to experience the effect of indirect decompression. I figured that the effect was based on the size of the cages, and I figured out the way to put in larger cages from posterior without destroying posterior element as much as possible. As a method, new endoscopic procedure was introduced. As a result, intervertebral body fusion was possible through the only 4 skin incision in PPS. Thank you very much.
Thanks a lot, Dr. Kanji, for your very interesting presentation. Now we will let Dr. Zhang finish his presentation. Thanks. So it's your turn, Dr. Zhang.
Can you hear me?
Yes.
Yeah.
Okay, I will share my screen. Sorry for the problem of sound. Can you see my slides? 能听到吗？
能听到，就是屏幕的话也正在开始共享。
哦，好，我就从这儿开始讲吧。
就是现在屏幕还是黑的。
没有分享吗？
没有分享出来，现在。
能看到吗？
现在还是不行，可能是电脑问题吗？
我在更换一个热点啊。
好，please wait a moment. Dr. Zhang Wei just changed the Wi-Fi. Thanks very much, Kenji Sasaki. And thanks for your Japanese team, Senya Ito and Takaki. Please wait a moment. Dr. Zhang Wei just changed the Wi-Fi. Hello, Dr. Yakov Fishenko. We have Professor Yakov Fishenko enter in the Zoom. Maybe we can we can move to the next speaker. Yakov Fishenko.
能看到屏幕吗？
可以。Sorry. Dr. Zhang Wei can share his screen now.
Thank you. I'm very sorry.
Dr. Zhang Wei, please.
Problem of my computer. I will start from the approach and position of the portal. 现在还没问题是吧？能听到吗？
可以听到，张主任。
可以听到。
The approach includes the fundamental approach. It is used for the discectomy and URBT, and the paraspinal approach for the foraminal decompression. The advantage approach is is a contralateral approach and the ULIF approach, and the cervical approach and the thoracic approach. This is a common approach for the discectomy and the URBD. First, I draw the red line. It is located at the junction of the spinal process and the lower margin of the lamina. And the blue one is located in the medial margin of the pedicle. And above the cross point is about 1.5 centimeter is endoscopic portal. And below the cross point, 1.5 centimeter is a work portal. This is a paraspinal approach. The horizontal line is located in the lower margin of the pedicle. Our dot point is isthmus, and the lateral green line, the vertical line is about 1.5 or 2 centimeter of the lateral margin of the pedicle. This is a contralateral sublaminar approach. I use this approach for this fragment migrating upward. And this is a translaminar contralateral approach. I use this approach for the disc fragment migrate downward. And this is a ULIF approach. The green line is percutaneous. The pedicle screw insertion line, and the endoscopic portal is located more lateral, and the cage portal is about in the midline of the pedicle, is more medial for the insertion of the cage. And this is a cervical approach. We draw the horizontal line. The red line is located in the disc space, and the medial margin. The medial margin of the pedicle is a vertical line. About 1 centimeter is endoscopic portal. Below 1 centimeter is work portal. And this is a thoracic approach. We can use the translaminar approach for the decompression of the OLF, and the transforaminal approach for the disc herniation. This is a summary of the different approach. We have the different surgical field in the right case and left case. For the left lesion, the endoscopic portal was located proximal, and the work portal was located distal. The left hand holds the endoscopy, the right hand holds the instruments. For the right lesion, endoscopic portal locates the distal, and the work portal locates the proximal. The left hand holds the endoscopy, and the right hand holds the instruments. This is the right side case. We can because the endoscopy is located in the distal direction, so we can see the cross section of the lamina. While this is the left side surgical field, we can see the surface of the lamina. For the instruments, there's different. We often use the zero lens. This is the zero lens is similar to the open surgical field. The right video shows the 30-degree lens. We must rotate the endoscopy to see the area where we are interested in. You must learn how to rotate the endoscopy. You can see the arrow of the endoscopy. When I rotate the 30-degree endoscopy, we can see the different surgical field. For the radio frequency, I prefer to use the radio frequency produced by Boss company. The big one is used for the cleaning of the soft tissue, and the small size one is used for the bleeding control on the surface of the dural or nerve root. This is another adjustable direction of the radio frequency. For the drill, sometimes we can use the shiver drill because the shiver drill has its own protective sheath. But when we choose the high-speed drill, we better use the drill with the protective sheath because the high speed, the root of the drill sometimes can damage the lens. This is another special drills is used when we open the spinal canal. So it is very safe when it is used surround the nerve root. This is another special bones I often used for the URBD procedure. This is the curved high-speed drill and was the ring saw high-speed drill, and this drill I used for the medial margin of IEP removement. Irrigation, I prefer to use the gravity. I think the pump is also a good option, but it is not very safe if your outflow is not fluently. So this is gravity irrigation. For the choice of the endoscopy sheath, I think the gap between the sheath and the endoscopy body should be large enough to keep the water flow as the column